Well, welcome everyone to our sponsor room. Really want to thank Astellas for allowing us to have this wonderful CE opportunity this evening. Looking forward to learning more about eye survey and mitigating geographic atrophy. So without further ado, we'll have Dr. Jessica Steen take us through our presentation from Astellas.
Thank you, Dr. Major. Wonderful to join you, and thank you for staying on this evening. On the East Coast, it is getting late, and I see many of you from the West Coast. So truly, thank you for staying with me this evening. Dr. Rodman is my colleague at Nova Southeastern University, so it's always wonderful to listen and to learn from her. And now we really get to take the conversation into a little more depth, into a little more detail in mitigating geographic atrophy and really focusing a little more on early detection and the importance of treatment intervention. Now, isn't it interesting that you think about this? 2 years ago, we did not have an FDA-approved treatment for geographic atrophy. And when you really think about retinal disease and continuing education in retinal disease, GA, if it was mentioned at all, it was mentioned really at the very end, the last couple of minutes, because there hadn't been anything new, anything successful. And Dr. Rodman was a perfect example of this today. That's what she came out swinging with, speaking about the pathophysiology, speaking about the disease process. This is such an important disease state for us as optometrists to be able to identify early, and to understand how we play such a central role in what happens next in that patient's journey. Now, we are going to be talking about Izervay, which is avacincaptad pegol, an intravitreal solution that is on label for the treatment of geographic atrophy that is secondary to age-related macular degeneration. Now, Izervay should not be used in patients who have periocular infections or ocular infections, nor should it be used in people who have active intraocular inflammation. Now, all intravitreal injections, including those with Izervay, may be associated with endophthalmitis and retinal detachment, and that's where our treating retinal specialists are so central to providing and to utilizing aseptic technique to administer any intravitreal agent, including Izervay, to minimize the risk of endophthalmitis. Now, we're going to dig into the safety data a little bit more, but one thing to be aware of, or one piece here, is that in clinical trials, Izervay was associated with an increased rate of neovascular AMD and choroidal neovascularization in comparison to the sham group when administered monthly through the trial period of 12 months. This was 7% in the Izervay group and 4% in the sham group. So patients should be monitored for neovascular AMD. And a transient intraocular pressure increase may occur after any intravitreal injection, including Izervay. The most common adverse reactions reported in patients receiving Izervay were subconjunctival hemorrhage, increased intraocular pressure, blurred vision, and neovascular macular degeneration. Now, isn't that interesting? On really a Monday night, when we're talking about two speakers, Dr. Rodman and myself, and I mean, really, we are so proud to both represent Nova Southeastern University. And this is a program tonight that is sponsored by and provided by Astellas, and I am being sponsored and I am being compensated by Astellas for my time. And this is a presentation for us, for US healthcare practitioners, and you've received your CE credit. And for this portion of the program, there are not continuing medical education credits that are available. Now, we think about geographic atrophy, and I think one of the big misconceptions is that it is a rare disease. When we look at the number of Americans who have or are impacted by GA, it's estimated to be about 1.5 million individuals in the United States that have geographic atrophy. And we are going to see some important parallels of geographic atrophy in comparison to another disease state that we manage commonly, open-angle glaucoma. Now, when we think about open-angle glaucoma and its diagnosis and the number of individuals in our country who have the disease but have not yet received a diagnosis, when we think about open-angle glaucoma, we generally say about 50% of individuals have disease but have not yet received a diagnosis. When we look at geographic atrophy, there is a greater need that's there. Up to 75% of patients who currently have GA may currently be undiagnosed. We really compare the prevalence of geographic atrophy to that of wet AMD, which really brings this disease state into our clinic in a comprehensive environment to ensure that we're assessing all of our patients with macular degeneration for geographic atrophy. Now, we think about early to intermediate stage that Dr. Rodman did a wonderful job to highlight in those beautiful images and what happens at the level of the RPE in the ellipsoid zone, especially as drusen develop and enlarge in intermediate dry AMD. Now, keep in mind that all patients who have AMD have dry AMD. However, some patients, in addition, also develop neovascularization. They have dry AMD, and in an advanced stage, they develop wet AMD. Other individuals stay more primarily within that advanced dry AMD space within geographic atrophy. But keep in mind that the natural history, even in the advanced state of geographic atrophy, the patient can develop choroidal neovascularization and wet AMD. So it is not one or the other. There is overlap in these advanced disease states. In geographic atrophy, we really talk about this continued progressive loss of the RPE, of photoreceptors, and the underlying choriocapillaris. And, we think about how our patients present. Early on, symptoms may sound a lot like other visual concerns or tied to other visual considerations that our patients may have. Early in the disease state, patients may report dim illumination, visual changes, dark adaptation changes, something that we can measure clinically, difficulty reading fine print, driving at night, or recognizing faces. This can sound a lot like other disease states that we expect and manage in an older population. Is this cataract? Is this uncorrected refractive error? Is this ocular surface disease? Or does this patient actually have age-related macular degeneration with early geographic atrophy? So it really is about thinking about, could this patient have early GA far before these significant advanced changes that ultimately lead to the loss of central visual acuity? Now, there is variability in the progression of geographic atrophy, and the disease state truly can be unpredictable. Some patients do progress quickly. In 2.5 years, GA can impact the central fovea, causing devastation to the central visual acuity. When we look at functionality and an individual's ability to drive, about 2/3 of patients in a just over 1.5 year period lose the ability to drive. And in 2 years, half of patients will have a 2-line or 10-letter loss in acuity. Now, the way that I tend to think about the progression of geographic atrophy, again, clinically, really mimics how we think about progression of open-angle glaucoma after diagnosis. We do, in the management of glaucoma, really think about identifying those quick progressors, because if someone progresses quickly early on in the disease state, they tend to continue to progress rapidly without significant intervention. And in open angle glaucoma, there are certain individuals that tend to progress more slowly. So it truly is important to identify those risk factors early on and to monitor patients early on to get an understanding of their true disease trajectory, with the goal and focus in finding those patients that may be the quick progressors that can have significant impact on their visual function and real quality of life in a short period of time. Now, it starts with, of course, looking at the retina, and color fundus photography can help us to document what we see clinically. But really, when we're looking at geographic atrophy and AMD, again, Dr. Rodman did a beautiful job of really highlighting the necessity at this point of multimodal imaging with an influence or with a focus on fundus autofluorescence as well as OCT. Now, on the left side, we can see our typical color fundus photography image, and looking carefully, we can find that area of atrophy, this hypopigmented lesion. When we look at fundus autofluorescence, again, we're looking at really the presence of lipofuscin in RPE cells. If there is atrophy of the RPE, the photoreceptors in outer retina, there is no lipofuscin that's present. There is hypoautofluorescence, that dark area. We're also going to carefully look for hyperautofluorescence, that bright white area on fundus autofluorescence. What this is indicative of is a higher concentration or higher amount of lipofuscin in the RPE cells. Now, lipofuscin is a natural byproduct of metabolism. So what this hyperautofluorescence tells us is that there is increased metabolism. This is stressed, metabolically stressed tissue. This is important to recognize. This hyperautofluorescence is an important marker for disease progression. And when we're looking at OCT imaging, this is not looking at our ETDRS printout, the overall map. We are sitting down at our device or our workflow platform and truly scrolling through each image, looking for RPE, ellipsoid zone, and choriocapillaris loss, and also focusing to see if we can find these areas of choroidal hypertransmission. Now, when we lose the RPE and photoreceptors, which the RPE is an important boundary that helps to attenuate the normal OCT signal. So if there's RPE, photoreceptor, and choriocapillaris loss, more OCT signal is able to pass through the tissue, which is an abnormal finding. That gives us that kind of barcode or hypertransmission defect that we see in geographic atrophy. Now, we're focusing on these high risk individuals at risk of rapid progression. Now, a couple of things to think about. We want to, number one, identify the presence of GA, and we see this fundus autofluorescence as a very valuable tool to incorporate to do so. On the left side, we see that single parafoveal lesion, a really nice PVD inferior, gives that overall shadow in the scan. And on the right side, we see the risk of multifocal lesions. We see the speckled appearance of multiple individual parafoveal geographic atrophy lesions. What we know is that multifocal lesions progress more rapidly than a single lesion. We also focus on location. Now, the foveal lesion, of course, this is devastating for a patient. This is an individual with severe reduction of central acuity. When we think about progression and rate of progression, the lesions that are extrafoveal, not impacting the center of the fovea, often grow more quickly than these parafoveal lesions. So again, we're scrolling through the OCT, but think about this from a functional perspective. This may be a 2025, 2020 patient, and we find this area of geographic atrophy outside the center of that patient's vision. They're reading that high contrast chart on the wall just fine. They may have symptoms of difficulty recognizing faces, difficulty especially in low light levels, difficulty driving. But think about if we identify this progression, or I'll say if we don't identify this potential high risk of progression, what will happen? What will this patient's future look like? This is getting awfully close to the center of the fovea, and thinking about when this lesion progresses, what the true impact is again, truly visually and from a lifestyle perspective, functionally significant. I mentioned this hyperautofluorescence. Again, this overactive RPE producing increased or resulting in increased levels of lipofuscin that can't be quickly recycled by this sick RPE that the lipofuscin is contained within. This hyperautofluorescence that often surrounds the areas of geographic atrophy is, again, an important risk factor for progression of GA. And laterality, we're looking for bilateral disease as the greatest risk for quicker growth of geographic atrophy. Of course, important to identify even unilateral geographic atrophy to watch for progression and development in the fellow eye. But keep in mind that this is often a bilateral but asymmetric disease that we see, again, as a really nice example of in the right and left eye, once again, utilizing fundus autofluorescence. Now, early detection is step one. And then we think about treatment options that truly can change their disease trajectory. So we're thinking about evaluating the data, assessing for progression and risk factors for progression, and then thinking about where to send these patients for consideration of therapy to our local retinal specialist. We've certainly changed our treatment patterns. This used to be something, as exactly as Dr. Rodman said, that was really a monitor, a supplement, a low vision consideration. Now, identification, step one, and to talk about potential treatment options for that patient, step two. Let's look at the clinical trial program to really understand the efficacy and safety of Izervay that was evaluated in the GATHER1 and GATHER2 trials. These were randomized, multi-center, double-masked, sham-controlled trials, all of the pieces we would expect of high-quality pivotal trials. And what the primary endpoint was the mean rate of geographic atrophy growth from baseline to month 12. And this was measured by, you guessed, fundus autofluorescence at baseline, at 6 months, and at 12 months. Overall, there were more than 600 people in both clinical trials as a whole, and just under 300 people received Izervay 2 milligrams every month. To be included in the trial, patients had to be at least 50 years of age. They ranged in age from 51 to 97. I think this is really important when we're assessing patients and talking about treatment options. Age is truly just a number for many of our patients. Being in your 90s does not mean that that patient is going to be a poor candidate. She's become one of my favorite patients. She's 93. And she's an individual who received her AMD diagnosis and really, truly one of the leading experts in the world who happens to be in South Florida, who had taken wonderful care for her for many years. She had seen me a little bit closer to home for her this summer for the first time. And we talked about her geographic atrophy. And I had introduced the concept of treatment for GA. And she, again, 93 years old, says, "But Dr. Steen, I have the dry form of age-related macular degeneration. There is no treatment for the dry form." And again, this is someone so in tune with her care, and it's wonderful to be able to provide her the information of there are potential treatment options. And this is someone who, if she can change her disease trajectory in any way, she's 93 years old, but really she is someone with good family support, good community support, and she is on board. So we really don't include or exclude people clinically based on being of older age. Best corrected acuity in the trial needed to be between 20/25 and 23/20, although the average visual acuity was between 20/32 and 20/40, which makes sense when we look at the inclusion criteria. That patients were not able to have, first of all, geographic atrophy that impacted that center point of the center of their fovea. This is why they had good visual acuity. They had to have a geographic atrophy lesion within 1,500 microns from the center of the fovea, but not touching it. Just close to the center of the fovea, but not involving the center of the fovea. And they had to have a total area of GA between 1 and 7 disc areas. And if they had multifocal lesions, one had to be at least half a disc area. For patients who had choroidal neovascularization or diabetic retinopathy, they were not able to enter the trial. Other exclusion criteria was GA secondary to any other condition. High myopia, we often think about peripheral retinal pathology. Keep in mind with your high myopes that at late stages of advanced myopic degeneration, patients can develop myopic macular atrophy. This is not the same disease process as geographic atrophy secondary to AMD, an important disease state, but only patients who have on label, again, as far as treatment, when we think about who is a candidate, a potential candidate for Izervay, these are patients with geographic atrophy secondary to age-related macular degeneration. Patients could not have had any prior treatment for AMD, including intravitreal injection, but they were able to continue and were able to have been on oral vitamin supplementation. Now, here's a little more detail about these patients who were included in the clinical trial. Their GA lesion within this 1,500 microns, but not quite touching the center on the left side, versus patients that were not included in the trial. If that center point was involved, as we see on the far right, they were not included in the clinical trial program. Or if their GA lesion was outside that central 1,500 micron area, again, patients were excluded. I think about this clinically to say, who are our most high-risk individuals? These patients who have GA lesions that are encroaching the center of the fovea, but still have good visual acuity. Now, from an efficacy perspective, in Gather1, number one, Gather1 and 2 both met their primary endpoints to slow the progression, to slow the growth rate of geographic atrophy as early as 6 months and with statistical significance at 12 months. In Gather1, there was a 35% reduction at 12 months versus sham and an 18% reduction in mean growth rate versus sham in Gather2. If we look at this a slightly different way, this is now pooled analysis that was evaluated after the clinical trial. This is not a primary endpoint, but another way to think about this alteration of the disease course with Izervay in geographic atrophy. We see that as early as 6 months, there was slowing of the lesion growth in the Izervay group in comparison to sham, and that effect doubled at 12 months. Once again, I think about this clinically and I say, if a signal, an efficacy signal exists at 6 months and it increases at 12 months, this is truly clinically meaningful as far as treatment through this 12-month period. Now, another way to look at this is, what does that change in area, change in mean growth rate really mean from a visual acuity standpoint? Now, over the 12-month period, once again, this is post-hoc analysis evaluating both Gather1 and Gather2 as pooled data in the Izervay group versus the sham group. And there was a 56% reduction in risk of vision loss in the Izervay group versus the sham group. Now, if we take this one step further and say, well, what does that change or what does that reduction in visual acuity loss mean? We can look at, as an example, the individuals who lost visual acuity sufficient to no longer meet our typical driving criteria. Now, while this differs depending where you are in the country, and in South Florida, we have fairly generous central acuity requirements for driving, what was determined is that there was a 58% fewer patients who lost the level of driving vision or level of vision required to drive in the Izervay group at 12 months in comparison, once again, to the sham group. Now, of course, this is not the only standard central visual acuity that determines anyone's ability to drive, but a way to think about this in a meaningful way. What does that change in area of GA growth rate mean? What does that difference in visual acuity mean? Ultimately, the impact on the patient's function is really what, of course, we're all, and including our patients, we're all most aware and most concerned about. From a safety perspective, Izervay is the only FDA-approved GA treatment that does not have a warning or precaution for intraocular inflammation or retinal vasculitis. Now, the common ocular adverse events, 2% or greater, that were greater in the treatment group than the sham group through 12 months were conjunctival hemorrhage, increased intraocular pressure, which was transient in most cases, blurred vision, choroidal neovascularization, eye pain, vitreous floaters at 2%, and blepharitis at 2%. Now, once again, important to look at this choroidal neovascularization incidence of 7% in the Izervay group, which was higher than the sham group at 4%. An important reminder that even patients with geographic atrophy, again, in the sham group, no treatment provided, can, and in 4% of cases in the clinical trial program, did develop choroidal neovascularization. It is a part of the disease process and the natural history of age-related macular degeneration. There was one case of intraocular inflammation in GATHER1. This patient was treated promptly and did regain visual acuity. And there were no cases of endophthalmitis, ischemic optic neuropathy, and retinal vasculitis. No adverse event of special interest that had an impact on long-term visual acuity. Now, the technology of Izervay, this is what's called an RNA aptamer. This is, again, high technology within the molecule itself that leads to low immunogenicity, which, again, involves that low likelihood of inducing true immune response. And RNA aptamers have a very high binding affinity. They bind strongly and to specific targets. Now, Izervay targets C5. When we think about this large complement system, this is slightly downstream in the complement system that allows the preservation of natural homeostasis and our natural complement system, which is an important part of our innate immune system. Now, bottom line, we've talked about early diagnosis. We've looked at the early effect as early as 6 months and significantly in 12 months with a consistent safety profile. Now, let's wrap up with looking at a case and, have to give Dr. Raffateri really significant credit. This is a beautiful case, and this is one of these examples where you think about early diagnosis and you think about the importance and the potential impact on this patient's disease trajectory. Now, Dr. Rodman mentioned it, family history, genetics matter. This patient is 63. She has a mother who had AMD, and really the report here is the left eye. The left eye visual acuity, she's dropped a couple of letters to 20/30, and her difficulty is difficulty reading at night. So let's look at the color fundus images, and in both eyes we can find a couple of hypopigmented lesions. This is very subtle, very, very subtle. If we think about evaluating this patient clinically, it might be easy to misdiagnose this patient clinically or with color fundus photography alone in having intermediate stage dry AMD only. And this is truly where multimodal imaging comes into play. Look at her fundus autofluorescence. That subtle atrophy that was apparent on, or not apparent, on color fundus photography. Look how significant the multifocal parafoveal lesions that this individual has in both eyes. Remember, she was concerned about the left eye. When we really look at the right eye, around or surrounding these hypoautofluorescent lesions, we find these areas of hyperautofluorescence, another risk factor for progression. This is bilateral, again, parafoveal, multifocal lesion with an individual with significant family history. On OCT, once again, we're scrolling through the scans to find these areas of focal RPE, photoreceptor, and choriocapillaris loss, and this choroidal hypertransmission, where with loss of the tissue, we can find and we can see that increased signal penetrating into the deep choroid in the right and the left eye. This is geographic atrophy, bilateral, multifocal geographic atrophy with significant risk, again, for disease progression. In this 20/30 eye, and this is, again, the symptoms that sometimes are very, I'll say, very possible to attribute to other pathology. Could that be early cataract? Could that be ocular surface disease? Looking closer, we see that this is a patient with bilateral geographic atrophy at risk for rapid progression. This is truly a true no-brainer as far as talking about mitigation and changing her disease trajectory with consideration of therapy, which may include Izervay. So I think one of the questions that is really practical to really wrap up with is, how do we talk to a patient? This is a new diagnosis, and really we do draw on our experience in talking to patients about open-angle glaucoma, the disease process and the treatment. Now, this is a patient, I would say. You're an individual who has age-related macular degeneration, and this is an advanced form of dry age-related macular degeneration. And in looking at your entire clinical picture, you do have risk factors for rapid progression. Now, we can't, just like glaucoma, we can't undo the damage that's happened. We can't stop the disease progression, but there are treatment options that are available to slow the progression of your geographic atrophy. And this is where we talk about referring to a trusted retinal specialist to, again, really dig in deeper to understand if this patient would be a wonderful candidate, as we believe that they would, for treatment of their geographic atrophy. It really has opened up the door for a line of communication between us as optometrists and our local retinal specialists to really get a feel and really make sure that we're on the same page with patients that we're referring, and really how these patients are evaluated or what information our retinal specialists may be most interested in consideration of treatment. Now, bottom line, keep GA on your radar. It's about early detection, digging through these scans, really exploring the data, asking the questions, exploring the data, thinking about progression, watching for progression, as well as thinking about risk factors which increase the rate of progression, and acting early with referring and working and communicating with our retinal specialists to truly make a difference for patients with GA. Now, in wrapping up one more survey, I thank you for truly spending your evening with us and wrapping up with me late this evening. There is a 5-question survey that will continue to support development of education, really surrounded on GA. Thank you very much. Wonderful to see friends, colleagues across the country. Have a wonderful holiday. Good night.